Hi everyone, I am Dr. Sagar Sahu and welcome to Veterinary. So today I welcome you to the third lecture in the series Orthopedics. So today we will be dealing with the orthopedic patient management mostly from analgesic point of view and fracture assessment score. Also we will discuss that how you will select an implant on the basis of the orthopedic assessment score, okay, or fracture assessment score. So before going to the lecture, some formalities. Okay, if you are really liking my channel and you have not yet subscribed, do subscribe to the channel. And if you are new, please definitely subscribe to the channel. You will get very good contents. And also you follow me in the Facebook where I post pictures of different cases which I get in field level. Important one is actually Instagram. Do follow me in the Instagram. In Instagram I post all the notes that I prepare for these lectures. Okay, also I post some case reports, some interesting case reports, and also I update regarding when the video is coming in Instagram. Okay, I am kind of active in Instagram. This is the book from which I am preparing all the lectures. Link to this particular book will be in the description. Along with the link to the book, you will find also a link to the notes that for this particular class. Also you will find the link to the PPT that I am using. Okay, so you don't need to worry about the PPTs or notes. Simply pay attention in the class, and after the class simply go through the notes. So let us go to our class. First one is the patient triage. It simply means that while assessing a patient from orthopedic point of view, suppose a fracture came to your clinic or hospital or college, so first you have to assess that whether anything is present that is more important than the orthopedic assessment. Like for example, okay, so to determine if there are problems that require immediate attention. Okay, suppose what happened, a orthopedic patient came but there is severe nasal bleeding, or suppose there is some particular wound where there is severe bleeding and a major artery is bleeding. So you need to take care of that before going to the orthopedic assessment. That is basically known as patient triage. It simply means patient prioritizing the things which you need to take care before orthopedic assessment. Patient triage from the orthopedic point of view, this is the definition. Patient triage from some other surgery point of view, simply it means you have to prioritize which things you have to give attention first. Okay, so this is not so big thing. This is patient triage, some technical terms. Next is analgesia. You have heard about preemptive analgesia. Okay, also I have discussed mildly in anesthesiology series. So there are some principles regarding preemptive analgesia. Preemptive analgesia is very important. Simply the analgesia is very important in orthopedic patients. You know that the orthopedic patients go through the moderate to severe kind of pain. So you need very good analgesia to calm the patients. So there are three principles. First one, the depth of analgesia must be sufficient during the surgery, and also the field on which you are doing this surgery, all the receptors, nociceptive receptors should be blocked, and this analgesic property should continue to post-operative period. Okay, in the post-operative period, these are the basic three principles: depth the analgesia, surgical field anesthesia, and also the post-operative analgesia. Next, there is some concepts in analgesia like preemptive analgesia. I just discussed preemptive analgesia. There is a concept of preventive analgesia. There is a concept of multimodal analgesia. What these are? Preemptive, I told you, preemptive here means you have to give the analgesic drugs, or you have to administer analgesic drugs before even the surgical insult. Okay, so here you can see before doing this castration or spaying, but in orthopedic, before doing an orthopedic surgery, you have to give the analgesic drugs. That is preemptive. What is preventive? Preventive simply means you have to give analgesic perioperatively, in and around surgery, perioperatively. Here the timing is not important. Like in preemptive, the timing is important. It should be given before the surgical insult. But the preventive simply means you have to give perioperative, in and around surgery. The strictness of this timing is not prevalent in preventive analgesia. The very recent, or not actually recent, it is multimodal anesthesia. It means you have to give multiple drugs, mostly two or more, multiple drugs, analgesic drugs actually, which acts in different mechanism of action. to make you understand, let me give you an example. Suppose there is an anesthetic protocol in which you have used butorphanol and xylazine for sedation. Then you have induced with diazepam and ketamine. Suppose, okay, there are many other protocols. For understanding, I am giving the example. So here let us see how many are analgesic. Butorphanol, it is opioid analgesic. It acts as a opioid on opioid receptors, mu, kappa and delta. Xylazine also having analgesic property. It acts alpha 2 agonist. Diazepam is not an analgesic. It has poor analgesic property. But ketamine is also analgesic. It acts as NMDA receptor. So here we are giving 3 analgesic agents. Suppose there is another protocol in which he used the pre-anesthetic same, kept same, butorphanol and xylazine. You can also use dexmedetomidine, xylazine, but instead of inducing with diazepam and ketamine combination, we used propofol. Here you see only the butorphanol and xylazine having analgesic property, but propofol has a pro analgesic drug. So in the patient who is receiving this protocol will have a better analgesia compared to this protocol. This is multimodal analgesia, multimodal approach to analgesia. Okay, you understood? Next there is a debate regarding the opioids versus NSAID regarding the preemptive analgesia which we should give. Okay, the book and I personally also I believe that opioids are far more superior than the NSAID when it comes to preemptive analgesia, and the preemptive analgesia concept was designed for opioids only. Why? Opioids, first point is opioids are very predictable. Okay, in action they are very predictable compared to the NSAIDs. Second, it has very quick onset of action. Very quick onset of action. The predictable nature is attributable to their CNS acting because they are centrally acting, so that is why. Next, the opioids do not alter coagulation. Okay, they do not alter the coagulation. Do not alter coagulation. When you are giving NSAID, there will be some defect in coagulation. If there is more bleeding, it may potentiate those effects. Next, apart from coagulation, also the butorphanol or buprenorphine, whatever you are using, opioids do not cause or potentiate, do not potentiate hypotension, while the NSAID can. Do not potentiate hypotension. Okay, so all these points are in favor of opioids, and also you know that opioids are very good analgesic agent for moderate to severe pain, while the NSAID are for mild to moderate pain. So the opioid is a clear-cut winner. Okay. So if someone debates regarding that the NSAID is better, there you will find multiple articles. I also discussed in anesthesiology when I was following Long and Jones veterinary anesthesia and analgesia. In this book also opioids are the drug of choice for preemptive analgesia. So regarding which opioids you should select. Okay. So if you are doing some minimally invasive orthopedic surgery, then you can go for butorphanol or buprenorphine. Most of the common orthopedic surgery, these two agents are sufficient. If you are going extensive orthopedic surgery like triple pelvic osteotomy, then you have to go for morphine, oxymorphone. Okay, so all these drugs, hydromorphone, morphine, these are basically for extensive orthopedic approach. If you are doing triple pelvic osteotomy, I think. Also it is used for approaching the prostate glands also. So all those things, when you are using approaching, then you have to go for the morphine. Okay, mostly. And regarding morphine, you should give it slow IV, so that we can prevent the histamine release. I have discussed this one in the anesthesiology session. Okay, morphine releases histamine. So this is basically under NSAID. These drugs should always be reserved for post-operative pain. Post-operative pain, they are excellent for post-operative pain management. You can use meloxicam, carprofen, okay, phenylbutazone, all those things you can use. Now you have understood opioid versus NSAID debate. Next, coming to our main actual topic is the fracture assessment score. So fracture assessment score is of three types: mechanical, biological and clinical. First one is mechanical fracture assessment. Mechanical fracture assessment. So here it is a scale from 1 to 10. Higher is the number, risk is less. Lower the number, it is more risky. Or you can say that you have to apply, go with caution. Okay. So here mostly three factors are seen. This particular assessment is done that so that you can tell that how strong your fixation should be. How strong fixation, whether internal or external. Mostly it symbolizes the internal fixation, but also external fixation also. So three factors. What? First one is the velocity of fracture. Velocity of fracture, it means how deeply or how deep is the impact. Simply means whether it is comminuted or three-piece fracture or two-piece fracture, transverse fracture or oblique fractures, like that. It means velocity, how impactful was the fracture. Why this is important? What happens when there will be high level injury? You see, there is a term known as composite. Composite is simply means it is the association of plate as well as the bone. Plate plus bone. Suppose you are using plate, any internal implant as well as bone. So what will happen when you will reduce? Suppose you have applied a plate here. This is a plate here and this is a plate here. Okay, let us assume in two extremes. What will happen? Suppose this is deeply impacted fracture. It means it is non-reducible. This is non-reducible. Here is simply a transverse fracture, easily reducible. What will happen when patient will put weight? Okay, in this let us here in little risk, let us understand. When there will be pressure by the patient, when patient will stand up, there will be axial pressure here. Okay, these are axial pressure. As this is a transverse fracture, the weight bearing or the force will be equally distributed among this implant as well as the bone. While in this particular, when there is non-reducible fragment, so here on the implant the force will be way much more than this bone, because the bone does not have any force building capacity or axial loading capacity. So most of the weight will be on this implant. So for this particular fracture management, you need very strong implant which can bear weight. Okay, that is the point of this velocity of a fracture. Next is there, how many limbs are injured. Suppose multiple limb, you need more rigid fixation systems. Okay, next is the patient size. Suppose a giant breed, you need a better fixation system. Okay, otherwise plate will bend or pin will bend, like that. Suppose you are using in a toy breed like Pomerian and in a Great Dane, there will be difference. The rigidity of this fixation system will be different. So on that basis, on these three parameters, velocity of fracture, simply what is the fracture type and how many limbs are injured, and also the breed of the or patient size. Okay, so these things will constitute the mechanical fracture assessment or mechanical fracture assessment score. Okay, from 1 to 10. Next is the biological fracture assessment. Here there are some parameters. First one, mostly the age. Older patient, you know that the healing will be delayed. Here actually this biological fracture assessment, it signifies that how fast the callus will be formed. How fast callus will be formed. Okay, so first is age. You know that in old age the callus formation will be delayed, so according to you have to score. Middle age nearly 4 to 5 in scoring. Young adult 6 to 7. Juvenile is very good patient for orthopedic healing, so that is 10. Next is health condition. You know that when there is problem with health, suppose liver is having some problem or kidney is having some problem, then you may tell that callus formation will be delayed. Next, soft tissue envelope. In the fracture site, you know that soft tissues are very much essential for vascular supply and fracture healing. While we'll discuss the fracture healing in subsequent classes, there I will discuss how healing occurs. You will understand better. Simply, when the soft tissue envelope is very good, then the healing will be much better. Okay, suppose there is some injury that soft tissue envelope is not completely gone. So in that particular case, it will be in the caution category rather than the little risk category. Okay, suppose there is a fracture of metatarsal. Suppose there is a fracture of metatarsal and there is a fracture of femur. You know that in case of femur, their soft tissue envelope is very good, while in case of metatarsal or metacarpal, whatever, in those particular areas, you know that soft tissue covering is very less. Okay, so those will come under 1 to 2 or 3 category, while the femur fracture may come under 10 category because it has very good soft tissue covering. Next, cortical, whether the fracture is cortical or a cancellous bone fracture. Cancellous bone fracture is a very good fracture from callus formation of point of view, because cancellous bone has high surface area, as well as you will find abundant osteoblast, which causes osteosynthesis, osteoblast. That is why cancellous bone heal faster than the cortical bone. Next, velocity of injury, high velocity injury, low velocity injury, it also comes under the first one, then the mechanical one. Also here, what is the degree of injury. Suppose there is a comminuted fracture, the callus formation will be delayed. Next is approach, how you are approaching to the case. Suppose you are doing some extensive approach, okay, like triple pelvic osteotomy, or you can say mini approach. Slightly you are doing some manipulation, which simply you have, suppose a femur transverse fracture, so you opened and give incision on tensor fasciae lata and simply opened and reduced. That is very minimal approach or minimal injury to the soft tissue. Suppose there is a fracture which can be reduced closely, you don't need to surgical approach. Okay, so in that particular case, healing will be better. Or when there will be approach, simply when you will approach something, you will give some trauma to the soft tissue envelope. When you will give some trauma to soft tissue envelope, the healing will be delayed. This simply as simple as that. Okay, so on this point you have to score all these things from 1 to 10, take an average, okay, for each point. Next is the clinical fracture assessment score. It denotes that the post-operating healing, how many days it will heal post of healing. Here comes the first one, the client compliance. You know that many of the orthopedic cases fail because of client compliance, because you will tell them that in this particular day the bandage will be changed, in this particular case you need some radiographs to be taken, you need to give the animal these medicines for this much period of time at this particular dose rate. So all those things are client compliance, how the client is complying to the post-operative treatment. If someone will be very casual, then definitely healing will be delayed. You know that you might have seen many owner will come just for their own satisfaction that they have brought the patient to the clinic or hospital. They do not intend to go for any post-operative care. Okay, so on those cases it is very poor patient compliance. Here it is rated in 1 to 2 or 3 in scoring. There are many patient owners who are very good at patient compliance, or those who will be having a little risk category or at the level of 10. Okay, next is patient compliance. You see, there will be owners who are very good, but suppose there is a breed, suppose compare between the Labrador and the Rottweiler. Okay, now we can easily tell who will have a better patient compliance. Definitely Labrador will have a better patient compliance. So the patient compliance is also important, because In some patients you cannot give tablets, so you have to go for syrups like that. Then some patients will be having some difficulty in when some foreign, suppose you have done some coaptation bandage, they will damage this coaptation bandage, like the breed like speech or Pomerian. If you will do some external bandage, they will simply rip that apart. Okay, so there is some patient compliance also. On that basis also you have to score. Next one is the patient tolerance. Patient pain tolerance. Patient pain tolerance. WIMP means who cannot tolerate those patients pain well, post-operative pain. Okay. While stoic animals, here it is stoic, who can take some amount of pain. Okay. For example, Labrador and Rottweiler. Similarly, Labradors, they are kind of stoic and they do well or cope well with the post-operative pains, while the Rottweiler will be a WIMP. Nothing, no pain. They won't bear some degree. Not all Rottweilers, but in general Rottweilers, they will not tolerate pain well. Okay. Next one is comfort level. Comfort level required. Okay. Comfort level simply means that suppose you are using some implants. Okay. How comfort that implant provides to that person. Okay. Also it is, implies that how the environment of the patient is there, where it can easily cope up. Suppose a patient is kept inside a AC chamber room and another patient in the garage, so the comfort level will vary. Okay, so those kind of comfort level is considered for this clinical fracture assessment scoring. Okay, so on these all these basis you have to rate between 1 to 10. Okay, now you got the mechanical, the biological and the clinical, then take an average. So when you will take an average, you will get some score. On that basis you can classify it as a low score from 1 to 3. You can score as moderate score 4 to 7, high score 8 to 10. So on this basis you can select your implant to be used. For example, in case of low scoring patient, which is very high risk patients, for that you may need bone lengthening bone plate, especially for comminuted fracture. We'll discuss the plates, nails, ESFs in subsequent classes. Don't need to worry. Simply which things you should select. Locking bone plate for low scorage, plate rod combination, interlocking nails, type 3 ESF, and here you should consider bone grafting. Next class we will discuss the bone grafting. In the moderate score, when the score is between 4 to 7, you can simply use a bone plate. Type 2 ESF, we'll discuss ESF, don't worry. IM pin plus ESF combo, interlocking nails. Here, bone graft may be considered, it may not be necessary. Next is the high score patient, very good patients, little risk patients. Okay, so in that case, you can go for type 1 ESF, IM pin circulage wearing. Most commonly in veterinary orthopedics, you may encounter this one, IM pin circulage wearing for oblique fractures. External coaptation, it is even more common for veterinary orthopedics. Okay, in the departments, in the field, it is the only thing which is available in case of fields. Okay, one field veterinary dispensary or veterinary hospital, it is the only thing which is used currently in most part of the India, I suppose. Okay, so these are the things, that is the low score, moderate score, high score. On the basis that, on the basis of this scoring, you can select your implant. Okay, so this is all about today's class. Next class we will go for the reduction, fracture reduction and their types, as well as the bone grafting. Okay, so till then, tata bye bye, take care.